Over the next 4 modules, we'll be learning the key concepts in interpersonal psychotherapy, an evidence-based practice in which clinicians help patients to solve an interpersonal crisis as a way of both improving their lives and relieving their symptoms. Interpersonal Psychotherapy Problem Area 1: Grief. Let's first highlight an important distinction in IPT related to grief: the difference between normal grief and complicated grief. Grief and loss are commonly accompanied by symptoms similar to depression, giving up pleasurable activities, changes in energy and appetite, and difficulties with attention, work, or school. After a period of weeks or months, these symptoms gradually resolve as the grief and loss are processed and contextualized in the person's mind. However, if the person is deprived of this opportunity to process their feelings around the loss, or intentionally or unintentionally avoids grieving, the symptoms mentioned above are often exacerbated or prolonged. In the words of Weissman, Markowitz, and Klarman, these patients suffer from not grieving. Avoiding the emotions leads the person to try to go through life containing them, distancing themselves from emotional life, and consuming great emotional energy. Another form of complicated grief is recognized as the tendency to make bereavement the sole focus of one's life for a very long period of time, to the detriment of meaningful activities and relationships. If an individual presents with symptoms consistent with major depressive disorder, or scores high on a PHQ-9 assessment, therapists practicing IPT should carefully assess for loss in the person's life. It's important to assess for both recent loss as well as past loss, since unaddressed grief often has a tendency to lay buried, manifesting as complaints which may seem entirely unrelated, such as somatic symptoms. In IPT, complicated grief is typically assessed if the grief is severe and lasts more than 2 months, but this may vary across cultures. Excessive guilt and suicidal thoughts are also more often associated with complicated grief. In IPT, there are 2 main goals in treating grief. The first goal is to facilitate mourning by gently eliciting affect in session and assisting patients through the feelings and thoughts associated with the loss. The second goal is to help patients re-engage in meaningful activities and relationships. These activities and relationships, while not totally replacing the lost individual, assist the patient in developing interests and passions apart from the loss. We can think of complicated grief as a process whereby an inordinate degree of mourning saps the energy the person would otherwise be using in meaningful activities and relationships, while the unwillingness or inability to experience the affect associated with the loss holds this process in place. The strategies that guide our interventions in treating grief correspond to our goals. At the outset of treatment, psychoeducation using the concepts of IPT familiarizes the patient with the frame and format of IPT, while setting expectations and building rapport. The heart of treating grief in IPT usually involves facilitating emotional release or catharsis in the patient during sessions. Finally, once emotional release has been achieved, treatment moves into establishing new activities and relationships to help the patient move on from the loss. Let's look at each of these in more detail. Psychoeducation in treating grief involves a 2-pronged approach: history-taking and an interpersonal formulation. History-taking first involves gathering general details about the patient and inquiring whether there has been a recent death in their life. If the answer to this question is yes, follow up with questions aimed at providing contextual clues as to whether they're experiencing complicated grief linked to the loss. Where were you when you found out about their death? What feelings did you have? Did you attend the funeral? What was that like? How did you handle the loss? Do you feel you've been able to mourn the loss? It's important to be as detailed in your inquiry as you can and record them in your notes during session or immediately after. If the person has difficulty tolerating questions around the loss, this may indicate the presence of complicated grief. We use the information we gather during history-taking to make an interpersonal formulation, which we subsequently communicate to the patient. An interpersonal formulation is a concretized case conceptualization focusing on the etiology, the cause of the person's depression. In the case of grief, a clinician would directly link the death of a close person in the patient's life, their difficulty grieving the loss, and their depressive symptoms. Let's take a look at an example of an interpersonal formulation for complicated grief. You have suffered the death of someone close to you, which we know is the most painful kind of loss there is. You've understandably had some difficulty getting over it, and you've developed symptoms of what we call complicated grief, which is a form of depression. It's a treatable problem, and it's not your fault. I suggest we spend the next 6 weeks speaking about what Michelle's death meant to you, what you miss about her, and how you can find a way to go on from there. To some degree, this means coming to terms with strong feelings you understandably have about her death. They feel powerful, but they're really not dangerous, and they should subside a good deal as you handle them. How do these ideas sit with you? After the psychoeducation phase has been completed and the patient has expressed a willingness to engage in a deeper exploration around the loss, we can then move into facilitating emotional release, which focuses primarily on mood and affect. In this phase, we aim to elicit emotions, validate them, and promote the patient's reflection on them. Patients who experience complicated grief often remember the deceased person and the circumstances around the death in a way that is lacking in nuance. You may hear all or none thinking, denial that the loss mattered, or conversely that it has made it impossible for the person to move forward. When patients begin to describe the deceased, their description may seem one-sided, either idealizing, or less commonly, demonizing the deceased. It is rare that this realistically reflects the range of feelings the patient felt toward the person. As clinicians, our aim is to draw out this range of feelings through exploratory questions. We might start by exploring the patient's remembered details preceding the death, the events, people, and places involved. If it seems useful, have the patient bring in belongings that remind them of the person and evoke memories. Next, we can move into inquiring into the connection between the person and the deceased, including both the positive reflections and less positive aspects of the relationship. Being sure to normalize the fact that we all have complex or even ambivalent feelings toward those close to us. Patients who experience particularly intense grief reactions may have difficulty exploring ambivalence toward the deceased. Depressed mood is not the only reason patients give up meaningful activities during grief. Sometimes patients must take time away from their lives to care for a dying loved one for an extended period of time. Upon the death of the person, a vacuum is left. Nothing can replace the loss of a loved one. However, it is still possible to re-engage in one's life following the loss. After patients are more comfortable speaking about and processing the loss, sessions can shift to focus on re-establishing activities and relationships which bring meaning and joy. It's important not to overcoach patients to re-engage in meaningful activities. A patient's reluctance to engage in activities most likely reflects that more emotional release is necessary. Once sufficient emotional release has been reached, a patient will often begin to seek out new opportunities on their own accord. Our job is then to reinforce the importance of these attempts and support the person through any related challenges. We achieve this through asking exploratory questions about the new activities and relationships. What parts did you enjoy? What parts were challenging? Would you do it again? What else might you like to do? It's important to remember that the overall goal of treating grief in IPT is not to end mourning, but to facilitate mourning and relieve it from common sticking points. Mourning itself should never be pathologized, since it is a natural and unavoidable process related to the death of close individuals. Through combining psychoeducation, emotional release, and re-establishing meaningful activities, we help guide our patients out of being stuck in complicated grief, establish a workable emotional relationship to the deceased, and re-engage in the world in ways the patient finds useful and desirable. This concludes IPT Module 1. Thank you for your time and attention. Please return next time for Module 2 on interpersonal disputes.